Good afternoon, and welcome to today's program, Leveraging Technology to Become the Urgent Care Model for Behavioral Health. I'm Julie Miller, Editor-in-Chief of Behavioral Healthcare. Today's program is sponsored by the Echo Group. Thank you to our sponsor, and thank you to everyone in our audience for giving us your time and attention today. And before we get started, we have a couple of housekeeping details that we'd like to go over with you. You will notice that each window on your screen can be moved by clicking and dragging, or you can enlarge and minimize by clicking on the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. You don't have to wait until the end of the presentation. You can submit it anytime that you have a question. But if you can't see this area, simply click on the red Q&A button. And to download a copy of today's presentation, please click on the link in the resources area in the lower left of your screen. And if you have any technical issues at all during the program, please click on the yellow help button and we will definitely help you troubleshoot the issue. And finally, you can also tweet during today's presentation through Twitter by clicking on the blue Twitter icon at the bottom of your screen. Simply click on the Post and Authorize buttons, log into your Twitter account, and begin sharing automatically at the event hashtag BHLiveWebinar. At this time, it's my pleasure to introduce our speakers for today's program. We have joining us today Chris Thompson, Senior Clinical Operations Director with Monarch, and Jason Cagle, HIT Manager for Monarch. And now I will turn the audience over to our presenters.
Thank you, Julie. My name is Chris Williams. I'm with the Echo Group to get things started. Just a brief note for introduction. We've been working with the folks at Monarch for 2 years now, and in that time, our relationship has really grown from that of a service provider into a genuine partnership. Over the past couple of years, they participated in our peer-to-peer summit, which is an annual gathering we have in New England for our customers, and it's a large user group. And in that time, we've learned probably as much from the folks at Monarch about technology as they have from us. The genesis for this presentation was actually born at peer-to-peer, just over some conversation as we were introducing ourselves around the table. And Daniel Brown, the clinical director there, was introduced the idea of there being the urgent care for behavioral health, and that really struck a chord with me and a number of folks throughout the conference. And as I learned more about this concept and this idea, the more excited I was about the work that they were doing and the folks they were helping. So we thought to ourselves here, what can we do to help Monarch really tell this story, this great story? And help them talk about the work that they do, the people that they're helping. And so we're just glad to be able to support them as they tell, as you learn their story, the Monarch story, and we're just thrilled to be a part of it.
Thank you, Chris, and thank you to everyone for joining. My name is Chris Thompson. I'm Senior Clinical Operations Director with Monarch. And Jason Cagle, our HIT Manager, will be commentary here in just a little bit. Wanted to go over kind of a little bit about Monarch so that you get a reference point of who we are. We're a large nonprofit organization in the state of North Carolina that provides services statewide to individuals with intellectual and developmental disabilities, mental illness, and substance abuse. We serve approximately 23,000 individuals annually, and we were founded in 1958. So now that I got that a little bit of housekeeping about Monarch out the way, I wanted to kind of go into Jason. I have a question for you. What do you think the average length of time for someone to receive a clinical assessment and, if needed, a psychiatric evaluation would be?
All right. So let's think about, I'm an IT guy. I'm thinking those two things are two separate appointments in two different providers. I know going out to see my doctor has taken at least 2 to 3 weeks to get an appointment. So to get both of those lined up, we're looking 4 to 5 weeks to see two different people.
So Jason says 4 to 5 weeks. So I want to ask the audience, if you will, join me in this question. What do you guys think out there? What's the average length of time for someone to receive a clinical assessment and, if needed, a psychiatric evaluation? If you don't mind just selecting one of those options, I'll give you a couple of seconds to select. I would love to have background music right now while we're waiting, like the Jeopardy theme song.
All right, let's go. Let's see what people say.
So 48% of the individuals say more than 4 weeks, which is almost half of the people who responded. And I would like to say that while that is the data that's out there, what we've typically seen, especially historically here in North Carolina, it takes anywhere from about 7 to 14 days for someone to receive an assessment. And then it takes them another week to get a treatment plan in place. And then it could be anywhere from 2 to 3 weeks before they can get in to see a psychiatrist to have a psychiatric evaluation, which all of those answers is too long. And that was our biggest question that we had. The answer is how do we give people access to services in a shorter time frame? And our solution to that was open access. And for you guys, you probably have heard this terminology as open access, or if you haven't, it's a completely new concept to you. Think urgent care center for behavioral health. So we all go, we may have a illness, you don't feel well. What do? You go to your urgent care and you get services that day for whatever condition that you're battling. It's the same thing for behavioral health, for open access. We want the individual to come to us the same day to be able to receive the services that they're looking for. So no appointments are necessary. It's a walk-in. It's Monday through Friday from 8 to 3 is our typical schedule, so that we can get the help needed to the individuals when they want it, which is when that they come in. So a little bit of why we chose open access and why it was so important to us. Number one is definitely because of getting people into care on a quicker time frame. Another is it's a nationally recognized practice. And then also, and one of the biggest ones is it produces better outcomes for individuals in need. When individuals think that they need help currently, what they're doing is I can go to the emergency room. Because they know if they go there, they can receive services. Well, that's what we want to do. Internally, we talked about how do we keep people out of the emergency room and we get them the services that they need. We know that people, when they go to the emergency room, can spend anywhere from, a couple of days, 3, 6, 7 days until they see someone or even get started in care, and it's not even the right appropriate care that they need. So what we want to do is we want to get people to come in to open access so that they can receive services today and be integrated into their care on the same day that they want and need help.
So the national average is saying, Chris, help me out with this one, that people take 4 weeks plus to actually get to where they can see a mental health provider. So instead they go into the emergency room and sit around for hours, if not days?
Yes, absolutely, if not longer.
That's a tremendous problem. So I'm glad that we're pushing forward with these programs and trying to work through this.
So one of the things and the reason for the webinar is yes, open access is a necessity that is needed for our community. But there are inherent challenges that come with that outside of just how do you make it work. That goes to we didn't have an implementation model that showed us what this needed to look like. There was an instance where we were told, sure, you can do open access. You can have somebody come in for an assessment, but you can't make it work with the psychiatrist piece same day. It's just not going to work. You're going to have to schedule that psychiatric evaluation appointment. We refuse to believe that. We push forward with our belief that people come in today. We want to make sure that they get the help that they need same day. Then it also, one of the other challenges was definitely the integration with different, multiples of software. So since there was an implementation model, we ended up having to figure out how we were going to make it work internally. When it came to our electronic health record, when it came to the processes that our front desk staff work, even all the way down to the therapists and psychiatrists. Another part of the workflow issues that came about was after the appropriate level of care was identified, linking those people to the correct staff. So making sure that the individuals were credentialed to see the person and who was available to do that. We also ran into challenges of being able to access our records in a timely manner and what that looks like, because we're talking same-day access. We're talking real time. And then the excessive amount of labor that comes with trying to coordinate services same day, which is a lot of moving pieces and a lot of moving parts that are all happening at one time. So our first attempt at this solution was it was an internal solution, which is Oasis, which was a custom utility for our outpatient check-in. The easiest way for me to try to describe Oasis is on the next slide, which is the airplane terminal model. So if you've ever been to an airport, you can look up and you can see when your departing flight is or when your arriving flight is. You know where the planes are in the steps. At each step of the way, it'll tell you what gate you're at. It'll tell you if you're arrived, if you're on the ground. It gives you an idea of where everybody's at in the system. That's how Oasis works for us. Oasis was a tool that was used to assist with coordination of care between open access clinics. We have 19 behavioral health outpatient sites across the state of North Carolina that are all providing open access services. So we had to develop this tool to help us to be able to talk to each location. We had to be able to, again, assist with the administration staff and also the therapists and psychiatrists at each of those locations. Oasis gave us real-time capabilities. We could see in each of our locations where someone was at in the process, whether they were in intake, whether they were in an assessment, or whether they were having a psychiatric evaluation, and allowed us to be able to see if resources needed to be shifted at certain times. It was definitely a way that we could have eyes on the ground and be able to adjust on the fly on an as-needed basis.
So I love that. I love that we're talking about like the airplane terminal idea. But one of the things that I think about Oasis and how I can describe it, I think about there's this awesome steakhouse that I want to go. It's got the best chef, the best meat. I go there and there's a line out the door. The check-in says it's going to be 15-hour wait, but I really want this steak. I need it. I'm dying for it. I've been a vegetarian, and I'm finally coming off that, and I'm going back to eating meat, and I want to get it from this steakhouse. And I'm waiting in line, and then next thing you know, the maitre d' comes around the corner, takes me into another office, and voila, there's my own chef making me the steak that I want, that I've been dying to have, right there. That's the idea. It's you, instead of just waiting forever to see someone where you need help, it's having that next step, giving that maitre d' the eyes to that there is another chef around the corner that can make the steak that you want and serve it to you the way you want it and the way you need it. So there's still something missing, though. We got the check-in piece. We got where we can see where the people are, where the largest volume of need was. We were moving our therapists and our prescribers around, our psychiatrists around, and and trying to get everything lined up, but there's still something missing.
So one of the big things that was definitely missing was the timely access to the electronic health record, because Oasis was a system that we developed internally that was outside of our electronic health record. So one of the issues that we were having is our staff were having to do dual entry information. And for you guys who know, if you ever do dual entry anywhere, anytime, you definitely lose efficiency of your processes. Another issue that comes up is your data integrity suffers because the individuals who are entering in the data may choose one or the other. They may view the electronic health record more valuable than what's going in Oasis. And we were finding our data wasn't coming out like we had hoped that it was going to. So that's really what we were taking the feedback that we were receiving from staff. The biggest issue from staff was complaints on what exactly was what exactly their needs were. So we went around to each of the 19 offices and we sat down with various staff and we had conversations with them about what is it that they need, what is it that they want out of a system. And one of the big things that they brought up is definitely integrating the airplane model, the Oasis model, with our electronic health record. They felt like it would save time. They felt like it would definitely eliminate mistakes. They felt like it would feel better to them. We talk about employee engagement all the time, and one of the things is what tools do we need to give to the staff to be able to, so that they feel effective. And having two systems was definitely an issue with staff because they didn't feel like they were being 100% effective.
So let's go back to my steakhouse reference. I mean, obviously, I'm a steak guy. I love steak, and one of the things that's tough for me is when I go to a steakhouse and I have to re-explain how I like my steak cooked. There's a particular way. It's not medium rare, or rare, because all those things mean different things to the actual chef. And so I then have to describe the color of how I want it and then describe where I want it cooked on the grill based on how hot the grill is or how long they've been cooking other things on the grill. So imagine if I could actually walk in and they kept a record of exactly how I liked it. And so then I can just sit down and I'll say, I'll have my usual. And that is an awesome feeling because they bring it out exactly the way I want. There's not that miscommunication between me explaining it to the waiter explaining it to the chef bringing it back out, and it's incorrect, and we go back and forth. So that's that single data entry. That's that link to the data integrity. That's the efficiency of the process is where it's all linked together. The data is stored as to what I need, when I need it, how I need it, and it's brought to me the right way. So we had to move into the next steps. We had to get past just having that check-in module, just having the Oasis piece where we're signing in to see where people are. We knew the next step is definitely to integrate Oasis with our electronic health record. Currently we use clinicians desktop from Echo, and it's been a great system for us, and it's led us into having some great capabilities. But part of those capabilities comes into how do we talk about what we put in our electronic health record, and so the question for that is what approach do we take? Is it just this innovative services approach where we say we got to have this open access model, and there's a group of clinicians sitting around talking about how they want to do it, and they hand a piece of paper to the IT guy and say, here you go. This is the clinical model all broken out. And he looks at him and says, that's not going to work. Our system can't do that. It doesn't make sense from a data perspective. So then is it just an innovative technical approach where the clinical director comes and says, we want to do this, and I have me and my IT geeks sitting around, and we're drawing out flow charts and making screens and putting everything out there, and they say, yeah, we don't even understand the first screen. Where are we supposed to click? What are we supposed to move? It's too difficult. There's too much typing. There's too much clicking. It's too colorful. And so you start to ask the question, who's on the team? Who should be part of this? And the real answer behind that, it's everybody. You got to have a team approach. And, so I'm going to take credit for this slide real fast. And you'll notice that at the center of this slide is IT. And, maybe that's that little hidden message that you always got to think about the IT piece of it. But sometimes it is that because we've moved to a digital world. We can't have paper records because paper records don't give us the access to the information that we need. I mean, I use the word data a lot, but sometimes data takes that personal piece out of what we're actually looking at. I mean, we're looking at clinical information that could save a life. And so that stuff is important. It's important to know that if I have a doctor in California that's talking to someone in North Carolina, they understand what their history is, what kind of medications they're on, what their allergies are, and it's important they understand it right then. And so getting back to my team approach, we also see we have HR there, we have finance, quality management, clinical. They're all part of that. I want to tell you an interesting thing. Chris and I were sitting there talking about this, and after I made the slide, we were like, is there anybody on there we forgot? And, we're trying to think about it. So, no, that's everybody. HR is handling all, that part considers all the licensures that's going on, that you have the right information, that they're seeing the right people based off what they're licensed for. Clinical's there to make sure we're gathering the right clinical data. We're building the forms in a way that's great for them. Finance is part of the group, so we know that we're getting the right information in so we can bill it out the door and get paid. QM is there to make sure that the data we're gathering is in a way that they can then run analytics on it to ensure that we're providing the best services in the best possible way. But then we started looking, there's got to be something. We threw that out there. We're missing marketing. And so we thought, well, what does marketing even have to do with this? And that's exactly what we're doing now. We're talking about what we're developing. And that's marketing itself. And so then we know we have to adjust this. We know we have to be flexible. And so we get into what your system can do. I mean, does it have that flexibility? Does your team have that flexibility? And so we looked at each time we had a meeting about open access, about Oasis, about moving it to our electronic health record. We tried to ensure that we have everybody involved so that there's input from each one of the groups because it's all different pieces.
So just to kind of hammer home what Jason was talking about, the team approach, it really is an approach from every single department coming together to make the system as a whole work. For us in open access, we knew what we needed clinically. We knew what needed to happen. We even knew administratively at each of the sites what needed to take place. But we had to involve IT to make it happen for us. We had to involve finance because anything that affects billing or time frames or making sure that claims are going out the door. We had to make sure that our system was set up in a way that the information that we're putting in could be processed. We had to incorporate HR and make sure that they were the right credentials were in place. As we build this in our system, we had to be able to make sure that if someone had Medicare, that they see somebody that's an LCSW and not an LPC. We had to make sure that that was in place in the system, so we had to involve each of those areas. And then QM, their involvement, because we had to be able to get this data out. We had to make the data, the information that we were putting into our electronic health record that was being integrated with Oasis, that we could get out and be able to use the data meaningfully. So one of the things that we did for our integration with our electronic health record when we started looking at it from the open access standpoint was what were our goals? And as we talked about some of the challenges of our workflows, we incorporated those in our goals of integration. We've already talked about the single data entry that goes, that increases the efficiencies of the processes. We talked about ease of use. Anytime you're in one system, it's just easier to use. Staff don't have to flip back and forth between two different software programs. We already know that if you're entering data in once, whether it's the intake time when they first walk in and it's just being put in one time, or it's being captured automatically, that your data integrity automatically improves because you're taking an extra step out, and in some cases you're taking out the ability for human error to happen.
That's that piece right there that I love when we talk about this, is improved data integrity. I'm constantly asked to produce different reports and about what's in the system. And if you're having to key information into one system and then turn right around to key it into the next one, imagine you've had a third piece in there and you got to turn around and key it in a third time. It's like the telephone game. By the time you get to that third, fourth, or fifth time that you keyed in the same thing, the data's bad. No longer are you writing a full note. No longer are you taking the time to spell out every single detail of the allergies or the demographics or whichever piece of it, because you're tired of it. You still have another 80 people in the waiting room that you're trying to ensure that you're seeing. And so you lose some of that data integrity.
So with that data integrity, some of the processes that we ended up having to consider that was mentioned in a previous slide was the whole, what does it look like on the day that they walk in to open access? So if you're an individual who walks through our doors, of course, you're going to have the check-in process. And then from there, you're going to go through a triage process. From that, you're going to go to a screening and intake, and then to an assessment, and then to the psychiatric evaluation piece. All that happens in one day. So you're talking 5 different processes, all happening, our goal, within 3 to 3.5 to 4 hours in one day. That's a lot of processes to make work inside of an electronic health record so that also you can coordinate that within 19 sites. For us to be able to handle the volume of individuals who come in, we've established a hub model. And just to give you a brief description of what our hub model looks like is we have found that recruiting for psychiatrists, LCSWs here in the state of North Carolina, there's pockets of locations where it's a little easier to recruit. Those are ones where we have our hubs that are stationed that can actually provide coverage for us to be able to serve the number of people that walk through our door, whether it's via telemedicine, whether it's if they're at a location that has a high volume, whether they see those individuals in person. Telemedicine helps us to be able to see individuals in rural North Carolina that may not have access to a licensed clinician, that may not have access to be able to see a psychiatrist. And we're able to provide them with the level of care that if they walk in today in rural North Carolina, that they are going to get the help that they need, which was our hope and our dream and our desire when we first started open access, that we could continue to serve the number of people that really need help. So part of that goes when you think about these processes to consider with these 5 different steps is that's not happening just at one site. That's happening at 19 sites Monday through Friday from 8. Our times are open 8 to 3, but we all know it goes till 5 or 6 in the evening that these processes are being performed. And so coordinating that was definitely something that we had to be able to do and integrate with our electronic health record to continue to improve our efficiency. One of the things as we integrate with our EHR, we're not losing the airplane terminal model with Oasis. What we're doing is the data is going into Echo and is being transferred automatically into the airplane model for Oasis so that we can still see, so that we can still track individuals' progress. It gives us that nice visual of where somebody's at in our system, but we're also integrating it with our EHR so that we can increase efficiencies and streamline these 5 processes that you see. So one of the big questions that I pose, and Jason, I'm gonna pose to you, is does our EHR offer us at Monarch a scalable flexibility?
I like this question because it's often that I sit in with Chris and his team, and they're talking about a new program that they want to push out, and I look at the scribbles on the napkins, and they'll have a form that's a paper form. Like, yep, we want it to look exactly like this Word document. Like, really? Is that all you want? Just that one little form? So then I asked the next question. I was, are you really thinking about that? Are you dreaming big, or are you just trying to maintain? Because if you're taking your paper documentation and just putting that paper document into a digital form, you're just maintaining. You're not dreaming. So I asked them, I said, guys, think about this. Let's just try and think about this all the way through. What are you trying to get? What's your end game? And so imagine that our EHR has full flexibility. It can do anything. It could drive you from one city to the next. And then once you put that program in, can you grow the next program? Can you grow that next location? Is it scalable? Or do you have to do it over and over? That's the question. So
my question to you, Jason, I don't know if you answered it with a yes, no, or I don't know, is does our EHR offer scalable flexibility?
Well, of course it does. It has to be. Let's see what our audience has to say, though. I see a top number is I don't know. And I think that's the typical answer, because most of the time you're thinking about just how to get by. You're driving your car. You don't think about souping it up. You think about putting gas in there so you can get to your next appointment. You don't take the time to drive by the tire store and evaluate some new tires and see which one will give you better gas mileage, or putting a different spoiler on there to give you better gas mileage because you have less wind resistance. You don't know. You just put the gas in and go. So that's the difference in our system that we've actually had such great success with. Like I said, we used a clinician's desktop design from Echo, and one of the very cool things about it is we can build our own custom forms. We can build our own custom screens, our own workflow validations. We can build reports out of all the data gathered and trust me, there's a lot of data gathered, and there's a lot of reporting that has to happen, because as we think about the processes that Chris was talking about, the check-in, the triage, screening, assessments, psychiatric evaluations, each one of those phases has a ton of data elements. And we need to put those in a way that's easy to enter, that it's easy to track, that it's easy to validate the information that's there, that it's easy to report off that it's there. I mean, I don't want somebody putting somebody in a program that's designed for children, but when we enter their date of birth, it shows they're 65 years old. That's bad data. That's bad reporting. And so this is that integration with EHR. We're trying to make sure that the information that's taken to that front side, that it comes out the back side the right way, that we can report off of it, validations are correct, the information is done right so that we can bill it out and get paid. And the other piece about this is our system gives us that global access to the central data. So I don't have a massive wall of file cabinets in every single office. We talk about we have 19 behavioral health locations. Well, there would be no way that I could have messengers running back and forth with records as they pull it from this wall of file cabinets. I have to have it in a central location. And we have to be able to have global access to that data at the click of a button. That's where the integration comes in. That's what we're looking for.
So I think to further your point, Jason, one of the very cool things that having our EHR integrated with Oasis from a site-specific viewpoint is I can be seen in one location, and I can have my assessment in one location, and then I can telemed to a psychiatrist that's sitting in another location without the need to fax information, without the need to, we don't have to wait on mail. All the information's already inside our electronic health record for the psychiatrist to be able to pull up, to be able to review, to be able to see it in real time. Again, he's not having to wait to be able to make decisions or to get information. And I think that was a huge, big integration piece for us, was to be able to have that flexibility that we can be able, again, to provide good quality service with information, with data.
I'm gonna show you a little man here. He's got a great quote. I'm not sure who this Jason Cagle guy is, but he's definitely clever with this one. The fact that we don't have to conform our business to the software. We actually conform the software to our business. So let's think about what that means. It means that we don't have to change how we think is the right way to serve our people. We can adjust our screens. We can adjust our forms, our workflows, our reports, the access levels, so that our idea of what open access should be is what we do. We're not locked into how an iPhone says you have to open your calendar. We can modify that and put a different calendar on there. We're not locked down to how your Android has 30 apps for the same thing that only one of them work. We can build the one that works and test it. And that's what we've done. We saw this need for open access, and we saw that it was absolutely necessary. Chris was telling us about the 19 offices and how people were coming in. I think you had a data point where you said you opened one office and that same day you had, was it 85 people walk in?
85 people walked in.
I mean, that's a tremendous amount of people walking through the door, and you got to figure out how to serve them. It's not that we're going to have 85 providers quickly rush over there across the state. No. We had to link them through our technology so that they can see the providers that we already had in place. And then we could start gathering some data elements as to, is that normal? Is it normal that 85 people every day walk in that office? What time do they walk in? Is it always from 9 to 1? If so, maybe we need to change the staff schedules. Do they always come in from 1 to 5? If so, maybe we change the staff schedule for there. Is it that we always have somebody coming in that speaks a particular language that we don't have staff for? Maybe we need to adjust that, and so we hire someone that speaks Spanish or Tagalog or Chinese. We can link those things back through our electronic health record so that we know which providers can have those capabilities.
So one of the questions that probably be asked is, where are we at with this now? We're in the process of still tightening our workflows. We tweak our business processes on an as-needed basis. One of the great things about the flexibility that our EHR provides for us is that we can make changes real time. Our changes are done internally. We have a development team that's their sole function within Monarch, is to continue to take our electronic health record and customize it to what is needed so that the field can be efficient, so that we can get the data that we need out of the system and that we can continue to grow. One of the things that we all know about our industry is it's ever changing. It has changed for years and years and years, and nothing has remained the same. The only constant is change. The only constant is change, and it's always going to be that way. And one of the cool things about having the EHR to be able to integrate with our Oasis product and also be able for open access is it is adaptable. It can conform to what we need when we need it, which is a really cool thing. And again, having Jason's group, he's head of our development team here for Echo, our Echo product, is being able to again meet our needs clinically, which is a huge win for us, again, to be able to serve the people that we need. And one of the things that I did want to point out, that I wanted to kind of share a little bit of data. I didn't put it in the slide, but I did want to kind of tell you where about open access and the individuals that we've seen. In October 2012, we initially had the thought process of, okay, what are we going to do as far as open access? What is this going to look like? And so in October 2012, we served about 139 people that month, came through our doors for open access. And you know, it was a learning curve for us at that point, but it was also a jumping off point for us to realize what an impact we were having. We do exit surveys when individuals leave from their first day when they come and visit us for open access, and consistently around 65 to 70% of the individuals that are polled say they would have either gone to the emergency department, they would have either not received services that day, or they would have waited months to receive services. So 65 to 70% of the individuals that took that survey back in October, so 139 people, would have all either done one of those three things. So by having open access, we're able to definitely provide good quality care to individuals in the time that they need and impact their lives. Now,
so how many people did you say walked in this month for open access?
So in April 2015, we had 2,800 people walk in our doors.
So 2012, 139, now 2,800. That's an amazing improvement based on the service models that we've put in place. But as Chris was saying, that's all happened through the team environment, through gathering the right data, through daring to dream big. But there's also been learning curves. We know we have to tighten up some workflows. We have some data elements that we have to ensure that we're analyzing the right way, that we're ensuring that we have the right people in place, that we're gathering the right stuff. We know we have business processes that we have to tweak some more to make sure that we are providing the best level of care to the people when they need it.
One of the things that, a word of advice as we get close to closing and winding this down is, one of the words of advice that I would give is to think you got to start somewhere. Don't be afraid to start. Don't be afraid to put into place, even if it's small, subtle changes that can make a big difference. I think as we have learned from a group, is if you wait until you think you know everything before you implement a system, or if you wait to make changes to how you're doing things, or whether you make changes in your EHR until you're 100% sure it's going to work 100% of the time, then you're never likely going to make those changes. And that's the great thing that we had when we did Oasis. We took Oasis. It was our internal tool. Again, we created that because there was a need that we had on how we were going to make this work. And we didn't have all the answers. We actually, that was developed. It was tweaked over time to be able to, as we learned new things, as we encountered new issues and problems, we were able to adapt. And then when we found out that, okay, Oasis is great, it got us to what we visually want to see. Now from a processing standpoint, now what do we need? Well, we needed that integration with our electronic health record to be able to, again, increase our efficiencies as we're trying to see more and more and more people. As you can see, when you have 139 people walk in October 2012, your lack of efficiencies isn't quite as magnified as when you get to be about 2,800 people that walk through your door. You got to be ever changing and ever being able to keep up with the amount of individuals and, again, provide good quality care in a timely fashion.
So what Chris is saying, he, in 1,000 words, is an innovative approach using innovative services, innovative technology. That we didn't have the technology in place, so they built one piece of it. And even then, we saw that wasn't enough. It only solved, one part of the equation. We had to then link into our electronic health record, and that took our entire team. It took IT, it took clinical, it took HR, it took finance, it took QM, it took our marketing group to all sit around and think about what we were trying to accomplish. How could we actually become the urgent care for behavioral health? We had to use our technology, but we had to do it together. And that's the best way to really think through this is think about your goals, what you're trying to accomplish, and then you bring your team together, and I think you guys can solve this.
So I just wanted to say thank you on behalf of myself and Jason from Monarch. I appreciate your time that you spent with us today on this webinar, as exhilarating as it might have been or not have been. And I think that we are ready for question and answer. I will turn it back over to Julie.
Great. Oh, Chris and Jason, thank you so much for an excellent presentation. We do have a lot of questions that came in from the audience, so we'll try to get through all of those. However, we'd like to remind everyone that you can use the Q&A area to the right of the slides to submit a question. So real quick, can you just reiterate the Oasis tool? That is something that was developed by Monarch, and it's unique to you. Is that correct?
That is correct. It is an internal. We had one of our development teams internally develop this tool. Jason might could speak a little bit more about the technical aspects of it, but it was 100% developed in-house to meet a need that we had.
Great.
Yeah, it's a Java 8 allow, it was like Chris was saying, it was developed in-house, and it gives us that check-in access.
Okay, great. And then as clients come through the doors, someone in our audience would like to know, do you still use paper to get the initial information from the client, or does someone enter that directly into the system?
So when they first come through the door, they are entered into our electronic health record, but they are given a triage form to complete the information that is paper. And then from that point, when the triage form comes back, it asks a multitude of questions. We're able to triage that individual, whether it's emergent, routine, or urgent. We hope in the future, and again, I believe with the flexibility of our software, we're hoping that we'll be able to take from that paper form and either be able to integrate it with technology, whether it's an iPad or whether individuals will have the ability where they can go online and they can fill out the information online, and so that it will integrate directly into our health record.
Okay, great. And I know you mentioned some numbers. In April 2015, you had 2,800 people come through your doors. Someone in our audience asks, in order for a member to get into the queue, how do they do that? Do they have to call ahead for an appointment? Do they just walk in, and are they placed in a lineup? How do you handle that volume of people coming in with open access?
So the way it works, you just walk in the door. They can just show up anytime between 8 and 3, and at that point in time, they come in and say, you know what, I'm here to see somebody, and they will immediately be, be handed the triage paperwork, of course, and then they will be placed in the queue at that point, where at that time they will be placed in the queue for a screening intake individual to take them back, where the remaining amount of information will be captured, whether it's insurance, health insurance, whether it's the rest of their demographic information, get all the consent signs and stuff like that. That will all be captured at that point. But they're still in the queue. They're just at the screening intake piece of the queue. And then from that point, they're still in the queue. They will remain there until a therapist claims them. And then after a therapist claims them out of the queue, then they will still remain in the queue until a psychiatrist claims them.
Okay, great. And someone in our audience is asking, have you been tracking the average wait time for a client to be triaged once they come in for treatment?
The average wait time for somebody to be triaged, so our benchmark is everybody has to be triaged within 15 minutes. And we are hitting that benchmark in all of our locations. I don't have the average number. I mean, it's less than 15 minutes, but that is our benchmark.
Okay. And someone in our audience is asking, how do you keep patients and staff safe in this type of environment where you have open access?
Keep patients and staff safe in this type of environment.
Could you ask back on that question what exactly they mean by safe?
We can follow up on that separately then, and we'll move on to the next one. So with 19 sites with open access and with your technology tools to back it up, did you roll out the open access concept and the tools all at once at all sites, or was it simultaneous, or did you gradually roll it out maybe 1 or 2 sites at a time?
That's a terrific question. I love it. So we piloted in one location to start with. We took the one that Jason mentioned. We had 80 people walk in at one time. We decided to pilot it there, and that was where we kind of cut our teeth, and we got kind of the process and flow down of what open access was going to look like, because we were unsure about the capacity of therapists that was going to be needed. We were unsure about the how many doctors or psychiatrists were going to be needed. And at that point, that was really back when telemedicine was starting really to take off. People were still a little unsure. So we took that one site and we learned from that one, and then we took it to all of our other locations after that without the Oasis product. The Oasis product was developed somewhere in midstream of rolling it out to all of our other sites. As we got to be in more sites, that's when we realized and went, yeah, we're going to need to be able to coordinate care amongst all of these 19 sites, and how are we going to be able to efficiently do that? So again, that's where I was going back to the end of the presentation is we took an idea, we decided to go ahead and run with it, and then we made changes on the fly as needed to improve efficiencies and process. All the while, people were still getting served. Again, our main focus was getting people the care that they needed, and then we were working and tweaking on the back end all the processes that needed to be put in place for efficiency.
Okay, great. And what was the timeline of that from, having the idea as a concept to the pilot to the actual rollout and training for the people who are going to be using it?
Those are great questions. I love it. So April 2012 was the brainchild of when we first had the thought of this is what we want to do. This is what we want to provide individuals. From that point, we started piloting that in the summer of 2012. So it took about 2 months to really kind of hash out what we were going to start with and what we were going to implement. And then from there, we took about another 3 to 4 months to really kind of hash out exactly what we were hoping and what we thought that it would look like. And then so about October 2012 is really when it started to really take off in the one location that we were at. And then shortly thereafter, we slowly but surely started rolling it out to other sites. And I can tell you for other providers, and one of the things that I didn't talk about in the presentation that I obviously forgot to talk about was that if you present access to someone for services, they will come. There has not been one location that we have not opened our doors to for open access that we have not been flooded with individuals who need the service and who need help. So, at first we were a little concerned, what is this going to look like? Are we even going to have people show up? It absolutely has. It is. The doors have come down with individuals wanting to come in and get the help when they need it. It is needed by individuals in the community.
Great. And we have another question from the audience, and there's actually 2 questions in this one. How do you keep track of where a client is within the facility? Are you using pagers or some other sort of method? And do you have official handoffs among staff members with clients? Can you address those issues?
We do have official handoffs between. So that's how we keep track, and is, for instance, if they go to the therapist and the therapist does the assessment and the individual needs to see a psychiatrist, they will warm hand off that individual to the nurse who will do vitals and do the safety check that nurses, that the nurses perform as they get ready to have their psychiatric evaluation. And then the nurse will hand them off to the psychiatrist at that point. And then from that, the nurse will take them back to the front desk where they will be checked out and either scheduled for their next appointment, which could be group the very next day. So they walk in today, they could potentially come in for group tomorrow for a group therapy session, or they will be scheduled for whatever their next appointment, or if they need to be referred to other services, then they will have all that information as well. But it's warm handoffs from each location. So intake to the therapist, therapist to the nurse, nurse to the psychiatrist, and then the nurse will take the individual back to the front desk.
Okay, great. Let's see if we can fit in one more real quick one here. Someone in our audience asks, how do you determine how much staff you need? I know you have a lot of data tracking the patients who are coming in for open access, and I'm sure that has probably helped you make the determination, but how do you really know how much staff you need to serve all these individuals who are coming in for service?
Great question. That's an awesome question. And being that I'm a data guy, I love these questions. So what we keep track is we know every single time slot how many number of individuals per location typically walk in to our offices. So we can plan and be able to see that the volume is higher on Mondays than it is on Fridays. So we staff up in the mornings. Again, 70% of the individuals walk into our offices between 8 and noon. So we staff up during the morning times from 8 to noon, especially in locations where the individuals, again, where more individuals are located. So those numbers are run through our electronic health record because we're able to track, again, all of our appointments are real time, that we're able to pull, again, time frames and locations. It's hard without, I wish I showed the data on where we got that information. It's a cool little data tool that we use, but
well, very good. Thank you so much. Thank you so much for sharing with us today. Unfortunately, that's all the time we have for questions. And I really want to thank Chris Thompson and Jason Cagle today for an excellent presentation. And I would definitely like to thank our sponsor, the ECHO Group, for making today's program possible. And also, thank you to everyone in our audience for participating today. We do hope that you will join us again in the future for another behavioral healthcare webinar. Thank you so much. This concludes today's presentation.